Hi, and welcome to the WellnessFX video training module on the thyroid panel, where we'll be talking about T4, T3, free T4, free T3, thyroid uptake, also known as T3 uptake, the free thyroxine index, and reverse T3. First, let's talk about thyroid hormone in general. Now, thyroid hormone is a very, I'll just say primitive hormone, in that certain different animal species may not have all the different hormones that we particularly have, but just to give you an example, and it's a rather random piece of trivia, but a tadpole cannot turn into a frog without thyroid hormone. A mother who is pregnant with a child, if she has low thyroid hormone, there will likely be some kind of developmental issues with her infant. Also, if a child, as they are growing, has low thyroid hormone, there will also definitely be some pretty significant developmental problems. Now, thyroid hormone is considered to be the metabolic hormone of the body. And what that means is, yes, it pertains to metabolism and weight loss, but really when you consider what metabolism is metabolism is essentially a cell's ability to do what that cell does efficiently and optimally. So again, thyroid hormone is the chief and primary metabolic hormone in the body, meaning that if thyroid hormone is low, then none of the cells of the body will do what those cells do because of sluggish metabolism within that cell. And consider all the different many symptoms, if you will, of low thyroid hormone or hypothyroidism. Constipation, for example, is sluggish metabolism of the gastrointestinal tract. Very often they'll have poor wound healing, and that is a sluggish metabolism of the epithelial cells to regenerate themselves. Very often people with low thyroid hormone will experience things like brain fog and inability to concentrate, and even depression, which is really sluggish metabolism of the neurons of the brain. They will very often be cold all the time. That's just a general overall sluggishness of the cells in their ability to actually generate heat. So there's a number of different symptoms that are associated with low thyroid hormone, all of them having to do with the metabolic rate of that given cell. So we need optimal thyroid hormone, and I'll tell you specifically which one, in order to have health in general. Yes, thyroid hormone, when optimal, increases our ability to lose weight, and if low, makes weight loss hard. But it goes beyond that. Every cell in the body has receptors for thyroid hormone, and we need it in order to optimize cellular health and therefore our total body health. So let's talk a little bit about thyroid hormone physiology. It really starts at the hypothalamus, up in the brain. Now, the hypothalamus is considered to be a master regulator of the body. The pituitary, on the other hand, secretes a lot of hormones, but the pituitary pretty much just knows what's going on, let's just say, inside of our body. The hypothalamus, on the other hand, knows what's going on inside, but from a number of different inputs as well. In fact, the hypothalamus is receiving information from our nervous system, from different neurons about temperature, about appetite, for example. It's receiving information from our immune system in the form of cytokines, and it's receiving information from different hormones in the body. Now, it accumulates all this information coming from a variety of different sources, and based on that, can make specific hormones that can impact different parts of the body or to impact the pituitary itself. And in fact, the hypothalamus makes a hormone, passes it down through the stalk here, called thyrotropin releasing hormone. Now, commercially that's not available to run, although it would be very helpful if we could, but TRH is produced by the hypothalamus when the hypothalamus determines that we need more thyroid hormone. TRH from the hypothalamus tells the pituitary to make its hormone called TSH, or thyroid stimulating hormone. Now, the pituitary will make thyroid stimulating hormone, which then tells the thyroid gland to make thyroid hormone. And we're not going to get into the specifics of how thyroid hormone is actually made, but essentially thyroid hormone is really a tyrosine molecule, which is an amino acid, and some iodine molecules. From that, in the thyrocytes, and when they synthesize thyroid hormone, they make a variety. They make what's called T4 and T3. They also make T2 and T1, which is, there's not a lot known about those. So in response to TSH, or thyroid stimulating hormone, that when the TSH receptors of the thyrocytes are stimulated, they release and produce more thyroid hormone. One is called T4, also known as thyroxine, and the other primary one is T3, also known as triiodothyronine. As the name would imply, T4 is a tyrosine molecule with 4 iodine molecules, and T3, or triiodothyronine, is a tyrosine molecule with 3 iodine molecules on it. Now, in terms of the amount that's produced, and this is very important, it's said that about 93% of thyroid hormone production is T4, and the remaining 7% is T3. The reason why, and the reason why T3 is written here in red, is T4 is considered to be metabolically inactive, in that it doesn't really do much in the body. And that's good, because this is our chief metabolic hormone. We don't want to speed things up too much, and ideally we don't want things to slow down too much. So what we want is to have the abundance of thyroid hormone be T4, so that we can convert that into T3 if we want, or convert it somewhere else if we want. So about 93% of thyroid hormone produced by the thyroid gland is T4, or thyroxine. About 7% is T3, or triiodothyronine. And here's what's really important. Now, just to jump down here, this is a cell of the body. Some hormones, like growth hormone, TSH, for example, insulin, they actually cannot get into a cell. On the phospholipid membrane, there will be a receptor for some hormones on the membrane itself. They're either charged, they're water-soluble, they're too large. For some reason, they can't get in. This is not true of thyroid hormone. In fact, thyroid hormone is one of the few hormones that not only can get past the cell membrane, but has a receptor on the nucleus itself, which again just tells you how almost primitive and primal thyroid hormone is. It can not only get past the cell membrane, but its receptor is actually on the nucleus itself. Now, I say that because if the thyroid gland were just to release these thyroid hormones, they could get into any cell that they want. And if the thyroid gland at the base of the neck was producing thyroid hormones and they were circulating around free, then they could very easily just be taken up by all the different cells surrounding the thyroid gland and never get elsewhere in the body. So, what happens then, and it's said that over 99% of thyroid hormone that's produced by the thyroid gland is bound to a transportation protein called thyroid binding globulin. This is a plasma protein made in the liver that binds onto thyroid hormone. It's a protein, making it it's inactive in the first place, but this cannot right now enter into a cell. So the thyroid gland makes thyroid hormone. It immediately is attached to thyroid binding globulin, which is a protein synthesized in the liver, and now cannot enter into a cell. This protein renders these particular hormones, I don't want to say useless, but they cannot get into the cell. They need to be liberated from that binding globulin so they can actually get into the cell and bind onto the nuclear receptor. So now, hypothalamus makes thyrotropin-releasing hormone, which stimulates the anterior pituitary to make thyroid-stimulating hormone, which stimulates the thyroid gland to make T4 and T3, the vast majority being T4, but both being bound to thyroid-binding globulin. Again, over 99% of thyroid hormone produced is bound to thyroid-binding globulin, plasma protein made in the liver for transportation. Now, this is circulating around the body, and on a blood chemistry, by the way, and we'll talk about these, you can see what's called free T4 and free T3. What that's really referring to is unbound T4 and T3. Right now, this is bound. It's unusable. Free T4 and free T3 are available by the body to do what it wants. So if on a blood chemistry you're looking at free T4 and free T3, what it's actually saying is the unbound versions of T4 and T3 that are circulating in the blood. And there is some because it wants to get into the cells. Then what happens, T4, because it's the most abundant, will go to the liver. Actually, I should say, this not only happens in the liver, it happens in the kidneys, it happens in some peripheral tissues, but because of the mass of the liver compared to the kidneys and because of other tissues, the majority of thyroid hormone conversion likely happens in the liver. Now notice T4 in the liver can be converted to a couple of different things. One is T3, which is the active form of thyroid hormone. The other one is called reverse T3. Now, what that basically means is, these are referred to as, reverse T3 is a stereoisomer of T3. And what that basically means, anytime you hear the word isomer or stereoisomer, Essentially, it's the exact same molecule, meaning it has all the same ions, atoms, elements, bonds, and everything, but there's one of those particular elements is somewhere else on that molecule, and it sort of has a mirror image to one another. Now, structurally, they have the exact same amount of everything. Nothing's been added, nothing's been taken away. In this particular case, to make active tritothyronine, or T3, an iodine molecule is found on one part of this molecule, and that same iodine molecule on reverse T3 or reverse tritothyronine is found on a different part of the molecule. Now, that sounds like not that big of a difference, but reverse T3 is thought to be completely metabolically inactive. Yes, it's T3, but it's the reverse form of it, completely metabolically inactive. T3, on the other hand, is the very active form of thyroid hormone, and we'll talk about what it does in just a second. Now, the question is why does T4 get converted into T3 and reverse T3? It's thought that this is kind of a regulatory step, because if there's ever a situation that the body needs to decrease its metabolism, like for example, it's been shown that people, when they go into a sauna, for example, that really high temperature speeds up the metabolic rate. And very often, if the metabolic rate is now higher, sort of artificially, that this system will shut down. You don't need more metabolic rate if you're already getting a higher metabolic rate from something like a higher temperature like a sauna. On the other hand, low-calorie diets, long-term low-calorie diets have also been shown to decrease the amount of T3. The reason being is the body doesn't want to continue a high metabolic rate if there's not a lot of energy coming in, and therefore maybe threatening survival. So long-term low-calorie eating will generally shut down the production of T3 so that the body can conserve its energy, not use all of its energy up for metabolic purposes if the calories are low. Now, I say that because if somebody has a high metabolic rate due to external stimuli like temperature, or if somebody has, for example, is on a low-calorie diet for a while, what the body will do is take T4 and make more of it into reverse T3 and less of it into T3 itself. Why? Because T3 is the active form. T3 can create a metabolic effect, but in the presence of a situation where the body wants to slow down the metabolism, it will increase the amount of reverse T3, decrease the amount of T3, or the converse could be true. So in the case where the body wants a higher metabolism, let's say, for example, it's a colder environment, and the body wants to speed up the metabolism because the external environment is trying to slow things down, what you can see is therefore more production towards T3 and less production towards reverse T3. So it's thought that having reverse T3, even though it's molecularly very, very similar, completely inactive, is a backup system so that the body can either speed up or slow down metabolism accordingly depending on the needs. So now T4 goes into the liver, and again, not just the liver, and converts to both in everybody, a little bit of T3 and a little bit of reverse T3 depending on the metabolic needs. Incidentally, the enzyme that converts T4 to T3 is called 5' deiodinase. And if you remember that T4 has 4 iodine molecules and T3 has 3 iodine molecules, that it's going to deiodinate. It's going to remove one of those iodines, 5' deiodinase. I say that because it's a selenium-dependent enzyme. And that means that selenium is required for that enzyme to work. If somebody's deficient in selenium, then they will have a poor ability to convert T4 to T3. Now, let's say we have T3. T4 has been converted to T3. Understand again that the bound form of T3 really can't be used by the cells of the body. It's only, and this is the reason why this is highlighted here, it is only free T3 that has the major metabolic effects, can go past the cell membrane, bind onto the nuclear receptor, basically tell the nucleus to go through what's called transcription, translation, and new protein synthesis, and that is how this cell has the metabolic effects of thyroid hormone. So again, constipation, sluggish metabolism due to low thyroid hormone. If this is one of the gastrointestinal cells and there's enough free thyroid hormone, or T3, this cell will do what it does because the nucleus is being told to make its proteins to make the cell do what it does. If this is a neuron in your brain, and with adequate free T3 levels, stimulates the nucleus, protein synthesis, in order to do what that particular neuron does. So this here is arguably one of the more important parts of thyroid hormone physiology, because if free T3 is low, it does not matter where the defect is. If free T3 is low, then this person will experience low thyroid symptoms, regardless of where it comes from. If you lack free T3, you cannot stimulate the cells of your body to do what that cell does, and you'll experience low thyroid symptoms, which is practically epidemic today when you look at all the symptoms that people are experiencing. So now what I'd like to do is we're going to go through this and talk about, on this particular panel, where you can find certain defects or different patterns, where the defect lies and why ultimately it's leading to low free T3. And right before I do that, because I'll be writing some of the panels up here, I just want to briefly talk about one of the markers, since we have this up here right now. One of the markers is called thyroid uptake, or T3 uptake, sometimes called T3 resin uptake. T3 uptake, and I'm really glad it's on this panel, is a great marker. It's a very old marker, and it's a marker that unfortunately most doctors just don't even run anymore, and it's very unfortunate, because thyroid uptake, T3 uptake or T3 resin uptake, is looking at the amounts of thyroid binding globulin. You can measure thyroid binding globulin levels on a blood chemistry, but T3 uptake is an indirect look at that, and it also happens to be a more accurate look at thyroid binding globulin levels. And you'll see why this is important in just a second. Because T3 uptake, or thyroid uptake, on this panel is a surrogate marker for steroid hormones, sex hormones like estrogen and testosterone, making it a really valuable marker, because not only can it help you identify where a defect is in thyroid hormone physiology, but it can also indicate if somebody is sort of estrogen dominant or testosterone dominant. And it doesn't always work out that way, but it's a marker I've looked at for years, and we've picked up hormone imbalances by this very archaic, sort of obsolete marker that can tell you so much about other things that are going on. So let's take a quick break on the video. I'm going to start to write down some particular patterns to show you defects in what areas may show up on a given blood chemistry. In this particular case, somebody's TSH shows up as high, the T4 is low, and anytime you see T4 without free or an F in front of it means total. Total refers to the total amount of T4, both free and bound completely. The total T4 is low, the total T3 is low, free T4 and free T3 are also both low, again being the unbound version. Reverse T3 is also low, and or could be normal. And I didn't write T3 uptake on here because we're not really talking about this with this pattern. Now, the question is where does the defect lie? And always go back to physiology to really interpret these panels. Never memorize these panels, because if you understand physiology, you can see these panels and figure them out for yourself. And that makes a far better practitioner than somebody that just memorizes these things. All right, so TSH is high, but T4 is low. So what's that saying? That's saying that the thyroid gland is not making thyroid hormone. The fact that T3 is low is probably also because you have low T4 and it's not converting anyhow. So everything's basically low except for TSH. Why would TSH be so high? Well, the pituitary gland and the hypothalamus are sensing the amount of thyroid hormone in the body. If that is low for some reason, then it's going to try to increase the production of it, of TSH, to try to get the thyroid gland to make more thyroid hormone. But what you see here is that's not working. The pituitary gland is increasing its production of TSH in an attempt to make the thyroid gland make more thyroid hormone, but it's not. A medical doctor could diagnose this as what's called primary hypothyroidism. Primary hypothyroidism because where's the defect? The defect's in the thyroid gland, not the pituitary. The pituitary is making adequate amounts of hormone, but the thyroid is not. It's not responding. So the defect in this case lies with the thyroid gland. There's really two major potential causes for this particular pattern today. The first and most common in industrialized nations is an autoimmune condition called Hashimoto's thyroiditis, Hashimoto's syndrome, or sometimes just Hashimoto's. What Hashimoto's is the immune system of the body targets one of two different proteins within the thyrocytes themselves of the thyroid gland and stops the ability to make thyroid hormone. If you see this panel, I personally believe that that individual should have the thyroid antibodies run to look for Hashimoto's, and those are thyroid peroxidase antibodies and anti-thyroglobulin antibodies, not to be confused with thyroid binding globulins, anti-thyroglobulin antibodies. Those two antibodies, if positive, are telling you why this particular pattern exists, because antibodies made by the immune system attacks either or both of those two proteins. One's an enzyme, one's a protein, and without function of either one of those, thyroid hormone production cannot happen. So that's why you see these low things or markers. Now, the other possible cause is a lack of iodine. The thyroid gland takes up iodide to make thyroid hormone, along with tyrosine, for example. And if iodine or iodide is lacking in the diet or because of poor absorption, for example, then this is what you can see. If there's no iodine, then you can't make thyroid hormone, which is the defect, which is what's really going on here. Another possibility as it relates to iodide is there are certain things called goitrogens that can actually block the thyroid's ability to bring in iodide. So perhaps the person has adequate amounts of iodine or iodide in their diet, but the thyroid is blocking it from coming in because of these things called goitrogens. Now, some goitrogens can exist. Soy, for example, is considered to be a goitrogen by some. Some of the cruciferous vegetables, if consumed in a really high amount, might contribute to that. But then there's also some of the halogens, for example, like fluorine or bromine, have been shown to act as goitrogens and maybe displace iodine. At any rate, if you see this, there's a good chance that that person may need to see an endocrinologist, because with low T4 and T3, you can either spend a lot of time trying to figure out why there's a defect, maybe it's iodine, maybe it's goitrogens, but really an endocrinologist will be, especially a good one, will be better set up to actually evaluate what's going on and really determine the best needs from a treatment option for that particular client. So if you see high TSH and everything else is pretty much low, then what you're looking for is likely a defect in the thyroid gland. The pituitary is trying to have it make thyroid hormone, but it's not. The defect is here. Number one cause is an autoimmune condition, Hashimoto's. Antibodies can help determine that, or some kind of issue with iodine. Again, you may want to go see an endocrinologist to try to figure that out. So here's another particular pattern that, unfortunately, I've personally seen quite a bit. And this, I will tell you, will absolutely go missed by most conventional doctors. And it's unfortunate because these people will be suffering to some degree from low thyroid symptoms. Now, if you notice here, and again, some of these bottom ones aren't necessarily as important, what we're really looking at are the top ones, TSH, T4, T3. In this case, TSH is low, but then so too is T3 and T4. So what that's saying is the thyroid gland is not making T4 and T3, but because TSH is low, it's actually not, it's doing what it's told. If TSH is low, it's not being stimulated to make thyroid hormone, and because of that, it's not making it. It only does what it's told. So if TSH is low, T4 is low, T3 is low, the question is where is the defect? Well, the defect is either, and you can't really figure this out, the hypothalamus or the pituitary. That for some reason, physiologically, this panel doesn't make sense. Because if T4 and T3 are low, you would suspect that a couple of different glands or organs in the body would pick this up, that there's low circulating levels of thyroid hormone. And because of that, would try to increase the amount of thyroid hormone by producing their respective hormones. But they're not. So the defect in this particular pattern, and again, what we're talking about is free T3. If the person has low T4 and low T3, chances are they'll have low free T3 and have low thyroid symptoms, despite the fact that it's actually higher up in either the hypothalamus or the pituitary. Now, in terms of what can cause this, it's actually a lot of things. And they all boil down pretty much to modern day society. Things that have been shown to suppress or inhibit pituitary production of TSH include things like lipopolysaccharides, which is an endotoxin, LPSs, an endotoxin from unhealthy bacteria found in our gastrointestinal tract. High levels of cortisol have been shown to suppress TSH production. A variety of different cytokines, which are some pro-inflammatory molecules produced by our immune system or our immune cells. Certain heavy metals, for example. Basically things of inflammation, stress, and dysbiosis or poor diet have all been shown to decrease or inhibit the pituitary's production of a variety of hormones, including TSH. So, realistic speaking, you can have this individual who may not be following a good diet or lifestyle and have them make some changes for 3 to 6 months, and this may correct itself organically without any kind of interventions. Otherwise, if this never really comes back up, again, at this particular time, most endocrinologists won't really appreciate a low TSH, especially if it's pretty close to being in the range, as well as low T4. But in terms of helping to really get some of these things going, really improving diet, detoxifying the chemicals and the pesticides and all the stuff that's in us, better diet, low inflammation, can maybe potentially help this. But the important thing to understand is this person is experiencing low thyroid symptoms, not because of a thyroid defect, but rather because somewhere in the hypothalamus or the pituitary that there's some kind of inhibition going on, likely due to some kind of inflammation, and only until that inflammation or those stressors are removed will the TSH then start to come back up, as will ideally some of the thyroid hormones. So now let's look at another panel. This particular panel has TSH is normal, so the pituitary is making adequate amounts of TSH. Normal T4, so the thyroid gland is making adequate amounts of T4. But if you notice here that both total T3 and free T3 are low, and reverse T3 is high. So TSH, total T4, free T4 are all normal, but total T3, free T3, and reverse T3 are abnormal. T3, both total and free, are low. Reverse T3 is high. Where's the defect? The defect here would be in conversion, because what you're seeing is normal TSH. The pituitary is happy with the amount of T4 that's circulating around. T4 is normal, so the thyroid gland is producing things as it should, as it's being told to, but conversion, probably in the liver, but it could be somewhere else, is not occurring properly. What you're seeing is T4 is mostly going to reverse T3, and less of it is going to actual T3 itself. Now again, reverse T3 is metabolically inactive. Active, or tritothyronine itself, is the active form, but what you're seeing is, therefore, low T3, low free T3, and high reverse T3. What we're really looking at, the bottom line, is low free T3, and therefore lack of stimulation of the nuclear receptors, and therefore not having the thyroid effects, and therefore having low thyroid symptoms. Hard time losing weight, hairs falling out, dry skin, poor wound healing, cold all the time, depressed, anemia. So all those things because you have no free T3, you have no free T3 because it's not being converted appropriately. It's being over-converted into reverse T3 and under-converted into T3 itself. Now, what are some potential causes of this? Unfortunately, it's a lot of the same things that cause pituitary suppression. Inflammation, cytokines, high cortisol, for example, low selenium, homocysteine has been shown to do this as well. But basically, things of modern living, high stress, high cortisol, lipopolysaccharides, heavy metals, lack of nutrients like selenium, as well as inflammation has all been shown to decrease conversion of T4 to T3 and increase then conversion to reverse T3. So only until those underlying blocking factors are fixed might you see an increase in this. Now, these individuals, they may benefit from thyroid hormone replacement therapy, specifically of T3, which will only be done by an endocrinologist. Or they can nutritionally try to pull themselves together, make some changes in their life, and see if just by doing so over the course of 3 to 6 months that you see a slow decline in the production of reverse T3 and an increasing in the production of T3 itself. Okay, now in this particular panel or pattern, we're going to take a look at T3 uptake. Now, T3 uptake is considered to be inversely correlated, meaning opposite directions, of thyroid-binding globulin, the plasma protein made by the liver that binds onto thyroid hormone and transports it around the body. So again, T3 uptake is inversely correlated to thyroid-binding globulin levels. Therefore, if you notice in this pattern or panel, TSH, total T4, total T3 are all normal. Free T4 and free T3 are low. Reverse T3 is normal, but T3 uptake is low. Now again, I'll say this a few times to make sure that it really sinks in. Once you get it, it's an awesome marker. T3 uptake is inversely correlated to thyroid-binding globulin. What that means is, if T3 uptake is low, that means thyroid-binding globulin is high. It's inversely correlated. If T3 uptake is high, that means that thyroid-binding globulin levels are low. In this case, T3 uptake is low. That means that thyroid-binding globulin levels are high. Plasma protein made by the liver, there's a lot of this. Now, just before even looking back at this pattern, think about what's going to happen. The body is producing more thyroid-binding globulin. So it's going to bind onto more of the thyroid hormone circulating throughout the body, making less of the free hormone actually being available. So in this individual, they too will likely have low thyroid symptoms because they lack free T3 to get into the cell. And if you notice, it's exactly what this says. Where's the defect? The pituitary is making optimal amounts of TSH. The thyroid gland is making optimal amounts of T4 and T3, which also includes conversion. So this is all good. Conversion is good, thyroid production of thyroid hormone is good, and pituitary production of TSH is all good. Where's the defect? There's no defect in thyroid physiology per se, but rather in thyroid binding globulin, the plasma protein made by the liver, is binding up all of the thyroid hormone, making very little free thyroid hormone available, and that's exactly what you see here. Not only do you see total T4 and total T3 are normal, but free T4 and free T3 are low. Why is the free version low? Because it's all bound up by that particular protein, thyroid binding globulin. And if this weren't enough to show that, T3 uptake, again, if T3 uptake is low, that indicates that thyroid binding globulin levels are high, which even if you didn't have the free T4 and free T3, you could assume anytime you see low thyroid uptake or T3 uptake. But having both just really confirms what's going on. The question is what would cause a low T3 uptake or a high thyroid binding globulin level? Why is the liver making more of this particular protein? The most common reason today, to be honest, is estrogen. That thyroid binding globulin tends to increase in pregnancy, for example. But any woman that's on hormone replacement therapy menopausally for estrogen, that's on maybe birth control, or just in general with having some kind of estrogen dominance and producing a lot of estrogen within oneself, that high estrogen helps the liver make more binding proteins. High thyroid binding globulin would therefore show up as a low T3 uptake or thyroid uptake, and therefore low free versions of the thyroid hormone because it's all bound up by this protein because the liver is making too much because of some exposure to some kind of estrogen. So in this given individual, one of the things you may want to consider is looking at estrogen. And as I said earlier in this video, T3 uptake is a surrogate marker looking at sex hormones, specifically estrogen and testosterone. And in this case, if it's a low T3 uptake, you may be looking at some kind of estrogen. And I will say that nowadays there's a lot of estrogen in certain creams that they may apply to their face or elsewhere for anti-aging benefits or whatever it may be. But if there's estrogen in that, they may drive up thyroid binding globulin, drive down T3 uptake, drive down the free thyroid hormones, making them hypothyroid in terms of their symptoms because they're lacking free T3. So let's take a look at a couple more panels. Now this is one that you wouldn't necessarily expect to have on someone that is experiencing low thyroid symptoms. I've definitely seen this pattern before myself, both in women and men, but only in some cases do they actually experience low thyroid symptoms, and I'll explain in those individuals why that's happening. So if you notice here again, it's very similar to the other one. You have TSH, T4, T3, those are all considered to be normal. Free T4 and free T3 are high, but again, if you just go back to the physiological chart, if you will, why would T4 and T3 be high in the free form? Because there's not enough thyroid binding globulin because the liver is not making it. So what we have then is more than enough free T4 and free T3. And again, to correlate, because T3 uptake or thyroid uptake is inversely correlated to thyroid binding globulin made by the liver, if T3 uptake is high, that's suggesting that thyroid binding globulin production from the liver is low. And similar to why thyroid binding globulin levels are high, estrogen will tend to drive that. Testosterone will tend to drop thyroid hormone binding globulin levels, and therefore that may be a reason why you see this particular pattern. Now, who would you see this on? Men in general tend to have a higher T3 uptake just because they tend to have more testosterone. Men that are taking testosterone as a part of hormone replacement therapy by their doctor, you will probably see this pattern somewhat. Also, in women with PCOS, polycystic ovarian syndrome, they tend to make more testosterone from their ovaries. This is not an uncommon pattern to see in a woman with PCOS. So those are some individuals that you might see this in. Again, the question is, number one, why? Chances are there's two primary reasons. One is testosterone, higher levels of testosterone, like I mentioned. Or two, consider where thyroid binding globulin is made in the first place. It's made from the liver. So if there's any kind of liver dysfunction, then it would stand to reason that it's not making thyroid binding globulin and it's not able to bind onto these particular hormones, and therefore that's why you're seeing this particular pattern here. Again, is there any other thing, any other markers on a blood chemistry that you can look at to see if it's liver or if it's testosterone? Well, if it's testosterone, you can run some of those markers, ask a male if he's taking testosterone, if the woman maybe has PCOS, or there's other sort of markers for testosterone. But for liver, you can look at things like albumin. If albumin is low, if AST or specifically ALT are high, then one of the things you may be looking at is dysfunctional liver and all the things it does, including making thyroid binding globulin, which is why, again, T3 uptake's high, thyroid binding globulin is low, either liver production or high testosterone, ultimately leading to high levels of free T4 and free T3. Now, is this a problem in people? If somebody doesn't have low thyroid symptoms, no, this is probably not too much of a problem. If somebody has this pattern and they have low thyroid symptoms, then what you're likely seeing is too much free T3, which if there's too much of any hormone, like too much insulin causes insulin resistance, too much cortisol can cause cortisol resistance, too much thyroid hormone can cause thyroid hormone resistance. So just consider that if this pattern exists and the person does not have any low thyroid symptoms, it's not necessarily a problem physiologically. Maybe they're maintaining well with these levels. If, on the other hand, they do have low thyroid symptoms, it's likely because of receptor downregulation due to excess free thyroid hormone that's actually causing this in the first place. Okay, a couple quick comments, and then I'll go over this last panel, and then we'll wrap this up. One thing I want to mention is this nuclear receptor for thyroid hormone, consider that there may be defects even with that by itself. And what you may be seeing, just so you understand this, is someone may have a completely normal thyroid panel. All the markers are within the range, they look great, but they're experiencing every single thyroid hormone, low thyroid hormone symptom in the book. One thing you may be looking at is thyroid hormone receptor issues, that for some reason it's not working properly. You can have, again, a perfect panel, but really, intracellularly, having a low thyroid hormone response or symptoms because of the receptor. One thing to take note is that there's also on a nuclear cell membrane the receptor called a retinoic acid receptor, which is for vitamin A. It turns out that for the thyroid hormone receptor on the nucleus needs vitamin A in order for it to work appropriately. And there's other things like inflammation that can cause these not to work correctly. But just understand that if you see a panel and it's totally normal, but they're experiencing every low thyroid symptom in the book, it may be thyroid related or it might not. But if it is, it may be because of inflammation. I think homocysteine can do this. Vitamin A deficiency can do this, for example. So it may be that they are, in fact, experiencing low thyroid symptoms specifically, but have a totally normal panel. The other comment I wanted to make is you can see multiple defects all happening simultaneously. I just went through them sort of defect by defect. But I want to show you that you can actually experience a number of them. So if you notice here, basically everything's low except for reverse T3. So what kind of defects are occurring here? Well, let's say TSH is low, but T4 is low. Going back to what we mentioned before, that would be a defect in either the hypothalamus or the pituitary, that they should be sensing the amount of thyroid hormone, and if they're not, then, or if they are, should be producing more TSH, and they're not. So where's the defect? Somewhere above. And that's why the thyroid then is not making T4 and T3. But notice here that T4 is low, but T3 is really low. Why would that be? That would be because this individual not only has sort of a pituitary suppression or inhibition, but they're also under-converting. So of the T4 that they have, which is low, T3 is not just low, but really low. That's because of the pituitary inhibition not making a lot of T4 in the first place, but they also have some conversion issues. And that's why, for example, this individual would have really low T3, both T3 and T4. And one thing I was just going to add to this, just to kind of throw a wrench into things, let's just hypothetically say that this exists. Low TSH, low T4, really low T3, but maybe normal free T4 and free T3, which would be very, very strange. Why would somebody, if they have low TSH, low T4, really are under-converting to T3, have relatively normal free T4 and free T3? And the reason why would be going back to the thyroid binding globulin. That if thyroid binding globulin was low, you'd have more free thyroid hormone available. Therefore, the T3 uptake would look like it was high. And this particular individual, believe it or not, because they have somehow normal levels of free T3, despite having many defects, have so many of these defects that they may not even be experiencing symptoms. So the point remains, and that understanding physiology is really the difference between a good practitioner and a phenomenal one, because you don't just memorize patterns, but rather you go to the physiology and you try to make sense of the pattern that you see to really accurately find the defect and therefore offer the best nutritional solution or conventional solution for that given client. Thank you very much. I hope you found this helpful, and I will see you in the next video.